VMR. Well, today we're going to start today. This is my first case to discuss. I am Jasmine, and many of you don't know me, but I am a medical graduate from Mexico. Hola a todos. And I am currently studying for my step 1. So yeah, outside from medicine, I like plants. So welcome all. I hope this will be a nice case. I really like infectious disease, so hopefully this will be one of those.
Yasmin, you're so funny. We all remember Yasmin for many things, but especially for her nailing a rare infectious cause of paniculitis presented by Kiara. So yes, we know you love infectious disease. Yasmin, how are you feeling?
I'm really nervous. Honestly, I'm really nervous because it's the first time I'm going to fully discuss a case with you. So hopefully I will keep this case going, the discussion 100%. Going. So yeah.
You. Everyone tells me I'm really intimidating and scary, so I understand why you're I'm kidding. It's very anxiety provoking and nerve wracking. But it gets better every single time, I promise. We're lucky enough that our dear Shema is actually going to be presenting a case to us. So Shema, take it away.
Okay, so you can start the whiteboard sharing. Okay, I just start with the chief complaint. So as a chief complaint, we have a 65-year-old male presenting with fever for 1 month and swelling of his both ankles for 7 days. And I stop here.
Okay, so should I start? So this is a 65-year-old man, an elderly. He has fever. So for red flags in fever, which is a sign of inflammation of cytokines production, I would say that if it's already for 4 days and ankle swelling, I would definitely think about infectious disease, or I would think about maybe it could also be something systemic, rheumatoid autoimmune. It could be, I would like to know if there is something going on in his pulmonary system or abdominal system and urologic system, especially with people, with patients that are this age. Many times they do not really notice when there is a infection in like a UTI, for example. So that will be my first, well, the next step for me to ask if he has any other issues, mainly urinating. And how is the fever also? It's only it says that he has been having for 1 month of fever. So we have to also, before we continue, go to the red flags of fever, and this is one of those. A fever for more than 3 weeks, I will definitely think it's a red flag. Other red flag would be like temperature of more than 40 Celsius. I don't know how much is that in Fahrenheit, I'm so sorry. If that comes with rash, if that comes with anemia, if the person comes with jaundice, if he has B symptoms, if he has lymphadenopathy, look for red flags, but this is definitely one of those. So yeah, I don't know, what do you think about it?
Yasmin, you took one sentence and you turned it into a poetic novel. That was superb. That was superb. Now, here's the key question for you. Okay, I want you to pretend this is real life. And you only get to know one more new thing. What would you want to ask Shema? Only one question. What would that be? Trying to ask, like, what's the most important next question in your mind?
Is there any pain?
Where are you meaning? In the ankle? In the ankles?
In the ankles, like that swelling coming with pain. So of course.
I think you're asking a key question, and let me try to explain why. So one part of this case is very clear, and another part is actually ambiguous, which is fancy for unclear. The part that is clear is that this patient is inflamed. The part that is unclear is where, right? And when people have ankle swelling, you don't know if it's pitting edema, which will take you into a journey of heart, liver, kidney, which we've done many times in VMR, or is this person have arthritis, which will take you into septic arthritis, crystalline arthritis. So here, the key question is, how do we find the source of inflammation? And it will come with really exam. And how do you distinguish edema from arthritis? And that will come up on exam for sure, unless the patient has obvious edema, like their abdomen is swollen and they have edema all the way to their thighs, then you won't have to. But that's the key question. And so pain will be very helpful. If there's a lot of pain in the ankles, that would be unlikely for it to be edema. But I will summarize our conversation now as we know this person has subacute inflammation. What we don't yet know is where it is. So the next part of our questions and evidence should be to find out, where is the inflammation? Is it a volume issue or a local inflammation issue? All right, Shema, give us more, please.
Amazing discussion. So I give you more information. So basically, as I said before, a 65-year-old male, he is from Eastern India, and he's presenting with swelling of his ankles. And he also noticed pain and redness on his right ankle for 7 days. He also reports having fever, cough, shortness of breath for 1 month. And when he was in a hospital, he was also incidentally diagnosed with diabetes mellitus. And otherwise, nothing is known. So just a question, should I also give you the clinical examination? Okay, so in the clinical examination, his body temperature was 102 degree Fahrenheit. So he was febrile. He was also icteric and dehydrated. Blood pressure 90/70, respiratory rate was 50, heart rate 128. Now to the pulmonary, the bronchial breath sounds on the left side, and there were bronchial breath sounds on the left side and bilateral crackles. To the abdominal, the spleen was mildly enlarged without any fluid in the abdomen. To the cardiovascular and neurological, this was normal. And on the local examination of his ankles, the ankles were erythematic and edematous. And on his right foot, there was cellulitis with pustular discharge. And his right knee was also swollen. Yeah, and I stop here.
Oh my gosh. Wow. Yasmin, I think you are solving a New England Journal clinical problem solving case presented by Shema. Here, let's do this. There's no way you can discuss this without having first to tell us what you find the most interesting. So you got a lot of data. What's the most interesting thing to you?
Basically that this person is already having jaundice, already having these bilateral crackles, because jaundice might be very well, okay, I'm not gonna lie. First of all, when I thought about this edema, ankle swelling, thinking, well, this is an acute one, it might be inflammation, it could be filariasis, because I might be biased and think, well, that this might be it, but it wouldn't explain jaundice, and it wouldn't explain this edema in other places, the bronchial breath sound with bilateral crackles. So maybe something in his liver, hepatitis, yellow fever, something viral. But then again, then we go to the extremities and see that there's already pustular discharge and a swelling knee. I think that there's something infectious going on there, not something viral. Like I scratched totally viral infection. So yeah, I'm going more into something bacterial or something parasitic going on there.
And what does the, I agree with all that. What does the splenomegaly do for you?
For me, the splenomegaly, it's telling me that there is something affecting the processes in the cells. I would like to know, we will know whenever we see the AST and ALT, if there is something cellular, if there is something obstructive. I want to know if it's intrahepatic or posthepatic.
Yeah, perfect.
So that would be, because that's jaundice, like etiology. I want to know if it's post or intra. I don't think it will be pre-hepatic.
Yeah, I agree with you. Yeah, I think that's such a beautiful approach to jaundice, is pre, intra, or post. And the pre-hepatic is usually hemolytic anemia and indirect hyperbilirubinemia, but there's no prominent dyspnea, there's no prominent signal for anemia with conjunctival pallor and things of that nature. So you're either in the liver or beyond the liver, so intrahepatic or post-hepatic, which essentially means that you're predicting that the bilirubin will be direct bilirubin rather than indirect bilirubin. And so as you're trying to say, is it in the liver itself or is it in the post-hepatic? Well, here's one powerful clue. Most jaundice with systemic disease is intrahepatic cholestasis. Extrahepatic cholestasis is usually a stone or a stricture or a local pancreatic tumor. It's very unusual for extrahepatic biliary disease to be accompanied by splenomegaly. Most of the time when the spleen is big, there's disease in the liver itself. So I think you can pretty reasonably say that this patient likely has inflammation, has a pulmonary disease focus, has hepatic disease focus, has splenic involvement, and has joint involvement and skin involvement. And we just learned that he has diabetes too. So a question for us, Yasmin, is to think, what kinds of infections should we worry about more in a patient with diabetes? What do you think about that?
Anything that would impair the neutrophilic response, that's the main issue with diabetic patients. Fungi, bacteria. So not so much parasitic because that's eosinophilic, but yeah, those are the main ones. Also, overall, they are like we could treat them as immunocompromised, but yes, it depends also on their how controlled is their diabetes.
100%. Yeah, I think that the rate of diabetic control will be a profound variable in this case. I think we have a lot left to clarify, but we have somebody who's from Eastern India, who has diabetes, who has a subacute inflammatory syndrome with involvement of the lung, the liver, the spleen, the joints, and the skin. And so I think the things that we're probably tracking are saying, hey, because it's subacute, I'm most worried about either an abscess or a granulomatous infection. And so really all the granulomatous infections like TB and melioidosis and brucella are all more likely in a patient to disseminate with diabetes. And so I think in this patient, the key thing to recognize now as you're taking care of him is that this is somebody who you should probably do respiratory isolation for tuberculosis. You have extensive pulmonary involvement, you have hepatosplenomegaly, and what you could have is erythema nodosum or what's called erythema induratum, which describes a ulcerative lesion in the back of the calf that can cause the discharge that this patient has. So this patient needs an extensive workout, but when you hear this data, you probably should do respiratory isolation for TB assessment. All right, Shema, tell us more.
So I give you no more. So first of all, I will start with the imaging. We performed a chest X-ray and it showed a homogeneous consolidation in the upper left lobe and a diffuse alveolar opacities in the remaining part of the lungs. We also performed an ultrasound, which showed mild bilateral pleural effusion and mild ascites with enlarged spleen. And and no other focal lesions. Yeah. And now giving you some labs. So his white blood count was 24,000. Just a moment. His peripheral blood smear showed toxic granulation and vacuolation. His ESR was 100. His HbA1c was 11.1%. Now I'm going to the bilirubin. Total bilirubin was 8.5. The direct one was 7. And to his total protein now, the total protein is 5.2. The albumin was 1.6. And the globulins were 3.6. And the AST is 160. The ALT is 82. The ALK phos is 1220. The GGT is 216. LDH 387. Creatinine is 1. CRP 233. PCT is 0.5. And we also took some cultures and performed gram staining and so on. So I give you only those that came out negative. So we did a urine culture that was sterile. We also performed a Thiel-Nielsen staining from the sputum, which came out negative for acid-fast bacilli. And malaria antigen was also negative. And the last aliquot will actually reveal the diagnosis. Yeah.
I've never experienced a bullet train, but my goal is to experience one very, very soon. And I feel like we're riding one right now with Shema. We're just like being launched in a ride of cases.
I forgot one thing.
Yes.
The oxygen saturation was 78%.
Oh.
And I also wanted to mention, he's, as I said, he's from India, and he also mentioned that he was exposed to recent floods. I don't know how to pronounce it. So
Yeah.
water. Yeah.
Oh, you nailed it. You nailed it.
Okay.
Recent floods. Yasmin, can you please tell me how you're feeling right now before you tell me the medicine?
For some reason,
Yeah.
I was thinking since the jaundice part, I was thinking leptospira because of the high prevalence and because it goes to liver, it loves the liver. But with these lungs,
Yeah.
and this it has a high phosphatase, alkaline phosphatase. I don't think that AST, ALT is that high to think there is something wrong in the liver primarily. And there was something else, the toxic ventilation evacuation means sepsis. This patient has a very bad infection, like his body is trying to fight this infection with everything they can. And thinking, okay, this is not a gram negative. So I'm thinking also this flood, for some reason I'm thinking flukes. And yeah, I'm just thinking maybe flukes, thinking clonorchiasis, they like going also. I mean, yesterday I was like all around schistosomiasis and stuff because they're like causing issues with the liver, but we will have another stuff also. Clonorchiasis also love going to the liver, but they wouldn't explain. Paragonimiasis will explain the lungs, but it wouldn't explain the homogeneous consolidations in the upper lobe. And also it wouldn't explain this redness in the ankle.
Yep. Yeah, it's impossible, really. It's impossible. I think it's impossible to make a lot of progress. And I think you're going through a very advanced list of differential diagnoses. I think Shema's putting up something on the screen. What is that, Shema?
That's the pus that was drained from his right ankle.
Okay, all right. Thank you. That's very helpful. Okay, Yasmin, I hope you become a future infectious disease doctor because your command of infections is excellent. What I think, how can you make progress in this case? I think that you have to probably stay broader than individual diagnosis right now in real life. I mean, Shayma's telling us that the next aliquot will reveal the answer, but in real life, you have to keep track of trying to understand what's going on. So let's try to understand what's going on. We now have almost for sure an intrahepatic disease process. Why? Because the alk phos is so high, and that tells you it's either post-hepatic or intrahepatic. And when you look, you see the AST and ALT are also high. So that supports the idea that there's something involved in the liver itself. And also, as we said, it's much more likely to be intrahepatic when there's a systemic disease involved. So we have the liver involved, we have the spleen involved, we have the lungs involved in a very extreme way. And we have that the patient has diabetes. So how can you start to filter through these things? I think that the combination of hepatic involvement and splenic involvement is very characteristic of a granulomatous infection. And that's very true of also of the time course. The time course here is a month. So when you're thinking of an infection for a month, most of them are granulomatous in nature. So let's address some of the infections that you brought up, including the possibility of flukes. And I think the flukes are possible, though toxic granulations and neutrophilia are uncanny for flukes. It's unusual for them to do so. You also brought up the excellent thought of leptospirosis, which is a consideration. And when patients have hepatic disease, they almost always have kidney disease. So that is a little bit unlikely in this patient. So those are the non-granulomatous disease processes that you brought up, just to address them. What about within the granulomatous diseases? I think here you know that the nidus of infection is in the lungs. The source of the infection, where it began, is in the lungs. So we have to go, you can go to the CP Solver's website and say, what are the pulmonary focus granulomatous diseases? And the short answer is the M's, Mycobacterium tuberculosis, and melioidosis, along with nocardia, all the fungi, all of them, all the fungi. This case is a very classic description for one kind of infection, and that infection is melioidosis. Why? This patient has a very unique combination of things. He's diabetic, which is present in almost 100% of patients with melioidosis, and he has two things that are characteristic of this infection. One, he has a subacute time course, month, but he also has present features of what is otherwise an acute disease. What are those features? He has prominent severe neutrophilia with toxic granulations. That combo of diabetes plus subacute time course, but also a marked neutrophilic aggressive response, is a very unique signature of this organism. What also is a subtle clue is the presence of flooding. So flooding, farmers, usually male farmers, are exposed in many areas, and flooding brings the organism out of the soil into the water, aerosolizing it into their lungs. So this case is a classic description of melioidosis. Now, does this mean that this case is melioidosis? No. What this means is that this is one of the very few times where you have a patient who has a pneumonia where you need to worry about gram negatives, because Burkholderia pseudomallei or Pseudomonas is a gram negative organism with high resistance profile and very, very morbid. So what I would do in this patient is I would be open to any granulomatous infection, but the one that is very likely to kill this patient very quickly are melioidosis and TB. But anything on the granuloma plus lung, which is on the website, CP Solver's website, is very possible. But I think the most actionable here is that infection in particular. Before we hand the mic to Shayma, I'm curious, Yasmin, now that I can see you're thinking really hard, what other thoughts have crossed your mind?
Yeah, it makes a lot of sense now that you mentioned Burkholderia. I would definitely do a gram stain of that abscess pus, and I mean, it definitely, it has already the signs of this acute pneumonia, and I will try to do a differential diagnosis with nocardia, with, I think there's also anthrax. I would also try to see if there is, well, they already we already scratch away malaria, so, and of course tuberculosis, but that would be it.
It's very tricky. Yeah, I completely agree with you. Very tricky in real life. I think the crux of this case is recognizing the signature of a granulomatous infection with splenic involvement and hepatic involvement, and trying to merge that with the fact that most granulomatous infections do not present with a white count of 24,000 with toxic granulations. That is a feature of acute pyogenic organisms. So what's the overlap? The overlap is, I would say, Salmonella, Yersinia pestis, TB sepsis, and melioidosis, as well as tularemia, I would say. That list is short. And in a patient with diabetes who's from Eastern India, who's had exposure to soil and flooding, I would really worry about that infection and treat him for it pending the blood cultures. Shema, educate us, please.
So you nailed the discussion. I will put a picture here inside, so which should actually reveal the diagnosis. So wait, I hope it is. Oh, that's not very big, but I tried to make it. So as I know, Yasmin was preparing for she was preparing for step 1. She can tell me what kind of bacteria we see. Is it gram positive or gram negative? Yeah, so basically we performed a gram staining of the endotracheal sputum, and it grew gram negative bacilli. And we also performed blood cultures and also the pus from the right leg, and it came out that this is Burkholderia pseudomonale. So it is a case of melioidosis. So you absolutely nailed it. And amazing discussion, Yasmin. So what I wanted to mention is when I read the case, so basically, as you said, the inhalation of this bacteria can be percutaneous through wet soils, but also during severe weather events, especially storms, through inhalation. Yeah. So the risk factor, diabetes, renal diseases, or HIV are several risk factors for melioidosis, and I've read it is prevalent in South Asia, also like Vietnam, Thailand, and so on. Yeah.
Yasmin, how do you feel now?
I really like infectious diseases, and of course, yes, this especially with this geographical special diseases. This is a very, especially in tropical climates and Southeast Asia, in wet seasons. Yeah. And this person has a risk factor, which is the diabetes mellitus. Other risk factors can be like chronic renal, liver, or lung disease, if they have immunocompromised states, and of course if they have agricultural work as their occupation. So yeah, it's very interesting to see what's to be prepared for every single place, especially in a country where the practice is so like worldwide. We have patients like from a lot of places.
Yeah, you know, I think it's amazing to see somebody who is in training who can approach solving a impossible case truly with joy. Like, this is your look on VMR. Like, when I was watching you, I was like, oh, I have to make sure that you're comfortable and that you're having a good time. That's my job, right? And you're just like so curious and so happy. And it's amazing to me to watch you navigate how hard this is and how challenging this is with just sheer joy. And I think that's inspiring for us to see, honestly, for us to recognize that that sense of feeling small and intimidated by these cases is not something we have to feel. And I think you modeled that really, really well. I think for those of you who are listening to this and you're like, what are you talking about? Like, how can somebody solve this case? And I think that in real life, you can't. In real life, what you really need to do is to continue to track all the possibilities. But there are two important lessons in this case from a medical perspective. One is fever, subacute fever and chest x-ray infiltrate in a patient from India, TB isolation. One, right away. And two, there are not many infections that cause subacute disease with prominent neutrophilia. Neutrophilia equals acute. So if you see subacute plus 24,000 neutrophils plus toxic granulation, oh my God, then the list is very short. What is that list? This is not comprehensive, but melioidosis, Salmonella typhi, tularemia are probably champions of that list. Okay, and what's the common denominator? They're all exogenous, meaning from the world, gram-negative rods. So when you hear subacute inflammation plus prominent neutrophilia, Google exogenous gram-negative rod. What does exogenous mean, just so I'm clear? Endogenous gram-negative rods are gram-negative rods that live on us. E. coli, Klebsiella, they're on us, and then they cause infection. Exogenous are things like Campylobacter, Salmonella typhi that live outside and then infect us. So I think that's the key finding in this case. All right, y'all. Thank you for an incredible, incredible journey. And I think Promise has the incredibly exciting task of recapturing the learning along the way that Yasmin peppered throughout. So Promise, take it away, please.
Hi everyone. First of all, Yasmin, I'm so proud of you. You did an incredible job and amazing discussion. And thank you everyone for participating in the chat as well. So we have a fascinating case of a 65-year-old male presenting with a 1-month history of fever and also bilateral ankle swelling for 7 days. And we've found that the final diagnosis is melioidosis. And I think the pivot points of this case is really starting with fever, thinking about the IMate mnemonic, which Yasmin did a really good job of highlighting, like thinking about infections, autoimmune, and looking into the systems that are commonly involved, like abdomen, pulmonary, and like urinary systems. And then also talking about the red flags that we would want to see, be on the lookout for. And then we talked about when it comes to swelling, we want to really ask the key question of whether or not this is a painful swelling or not, because that will really clue us into two different directions in our differential. And I think when we saw that this patient has jaundice and splenomegaly, we were really thinking more about like an infectious cause because of multiple organ system involved. And then we really talked about the subacute time course and this patient's past medical history of a diabetes, and then we found out that this patient has a toxic granulations, which would indicate a severe infections. And I think the key takeaway from this case is noticing the time course and seeing how is multi-system involvement, and then having a neutrophilia. And that really clue us into, and also the history of diabetes, really clue us into thinking about melioidosis. And with this patient's risk history of flooding. So thank you everyone for this amazing case and for the amazing discussion. And yeah, I just learned so much.
Oh, did you hear that? That was literally, I was timing it. It's 2.5 minutes of like focusing on the fundamental aspects of this case. I promise, I just want to say publicly, it's actually much easier to do teaching points by literally like saying again what you wrote on the whiteboard, but you didn't do that. You put in a narrative, focusing on the highlights of the case and summarizing the journey in a very captivating way. That was absolutely incredible. It's a privilege to to be here with you guys and to watch Yasmin do what she did and to watch Promise what she did. And I hope for those of you who are new to VMR or seeing this for the first time, you can do this too, I promise. So thank you, Promise and Yasmin for inspiring us all today. All right, see you all tomorrow. Bye.